Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now. Dr. Nathan Goodyear here. Welcome to another Hot Take. That's prescribed.com, Hot Take. We'll talk a little bit about surgery and the impact on the immune system. And actually a 2024 study, actually looking at two repurposed medications in oncology here. Two that you may have heard of, propranolol and then Celecoxib, also known as Celebrex. But let's start off first with this quote you can see here on the screen. Surgery cuts out the tumor, yet it silences your immune system. Now, I come from the arena of surgery, primarily as a pelvic floor surgeon, but that post-operative immunosuppression period is really critical to the risk of metastasis, to local recurrence, and even post-operative infection. Now, this study, again, published in 2024, was looking at the perioperative period, looking at the combination of COX-2 and beta-adrenergic blockade, that's with propranolol, in patients with colorectal cancer. These patients basically required to have disease that could be resectable, but they were then adding this in to see if they could negatively impact the ability of the immune system compromised after, well, actually during and after surgery, how that would then impact the immune system that then could propagate recurrence and metastasis distally. You can see this is repurposed medication in oncology. Now, it's important to understand that when we look at surgery, I call it one of the unholy trinity triad, obviously, surgery, chemo, and radiation. But when you undergo surgery, people will focus on biopsies and the risk of metastasis. It's a real risk, but it's very rare, but it's still very risky. It does increase in risk when you go from a fine needle aspirate up to a core biopsy and then up to actually a resection. But here, dealing with surgery, we're talking about resection and the impact that it has in that surgery and immediately thereafter. Primarily, it's affecting the immune system. It triggers chronic inflammation. It triggers stress, cortisol, epinephrine, norepinephrine, which are catecholamines, and it actually creates an immune suppression. Now, it's important to understand a tumor has been historically referred to as a tumor that does not heal. Yet, when you go in with surgery, you're creating a tumor where a tumor that does not heal lives. So what you have the potential for creating is an aggravation where the tumor can actually locally recur or send out circulating tumor cells to spread. And again, that will activate not only the increase in circulating tumor cells, but increase risk of dormant micrometastatic sites, thus promoting the risk for metastasis, which 90% of morbidity and mortality in cancer is when it's spread. Now, this brings up a quick topic that I want to touch on later in the future, what's called antagonistic pleiotropy, which is you have a short-term gain for a long-term loss. You gain short-term survival, but what you do is you sacrifice long-term because of the impact for that short-term gain. So they were, again, looking at that perioperative mechanism or time period to try and work and reduce the metastatic risk associated with that. Again, the trauma associated with surgery itself, like a biopsy, but on a major scale here, again, dealing with patients with colorectal cancer, because that increases a tumor that does not heal. It increases inflammation, stimulation, and growth factors. This can create the pro-metastatic setup, the staging, if you will, by increasing blood supply, angiogenesis, again, a wound that does not heal. You create a wound, you add in the desire for new blood vessel growth. You create a local immunosuppression, and you actually, we'll talk about this in just a second, you can actually create immobile cells to become now mobile or modal, and thus go from an epithelial to mesenchymal transition and spread. And then this then reduces overall survival because of the impact of the stress, impact on the immune system, and it decreases the immune system's ability to target the cancer. It actually increases the survival of the circulating tumor as they seek out distant areas to colonize. So there's several different phases here that we need to be concerned about in the post-operative immunosuppressive period. First is that initial 0 to 24 hour phase where we get decreased natural killer cells, which they do exactly what their name implies. They have an increased neutrophil to lymphocyte ratio, which is critical in assessment of immune and chemotherapy response following surgery. And you get elevated interleukin-6, interleukin-10, prostaglandins, and cortisol. All of this is going to help to create that immunosuppressive environment. And then that day 1 to day 3, as you can see on the slide, you get decreased antigen presentation, T cell activation, you get immunosuppression. You get an increased risk of infection and tumor dissemination, as I mentioned, increased survival of the circulating tumor cells and increased colonization. And then looking at that kind of intermediate phase of phase days 4 through 7, you see actually an increase in immunosuppressive cells. You see increase in myeloid-derived suppressing cells, T-regulating cells. And what they're doing is they're going to actually create an immunosuppressive environment. In fact, you get a shift of the T effector cells versus T-regulating cells, creating an immunosuppressive or a pro-tumor environment and not an anti-tumor environment. And then when we look at the recovery phase, days 8 to 14, this is very variable, but this is where the immune system begins to somewhat normalize. But in the elderly patients and in patients with significant comorbidities or malignancy, they are going to be much, much slower in their immune system to respond because it's already dysfunctional, it's already compromised to a degree. And so this is just the generality post-operative immunosuppressive period that we're looking at. Now, the pharmacological intervention here, repurposed medications in oncology, again, Celebrex or Celecoxib, COX-2 inhibitor, they use 200 milligrams twice a day, and they use this 3 days pre-op, and then they use it throughout the 7 days post-op that they followed in the study. And the propranolol, which is the beta-adrenergic blockade, or beta blockers as we like to call it, was 40 milligrams twice a day, taken that same day, 3 days pre-operative all the way to 7 days post-operative. And it was a combination of these two. So it was only the combination, it wasn't used individually. The study design, they looked at 120 patients, again, with resectable colorectal carcinoma. And obviously they excluded those that for clinical comorbidities, they couldn't take either one of these medications. And they actually did tissue analysis at the time of surgery, and that gave us the ability to look at transcriptomic analysis. But then following preoperatively and throughout, they actually followed with collecting blood, and they looked at the baseline, which is preoperative day of surgery, day 1 post-op, day 3 and post-7, and day 7 post-op. And the primary endpoints was looking at the metastatic biomarkers. They looked at matrix metalloproteinases. They looked at vascular endothelial growth factor. They looked at epithelial to mesenchymal tumor markers such as Vimentin, and also looking at epithelial cadherin, also known as E-cadherin. Talk about that in a second. Epithelial to mesenchymal tumor markers such as Vimentin, and also looking at epithelial cadherin, also known as E-cadherin. Talk about that in a second. They looked at immune function markers such as T cell population, natural killer cell activity. And then they looked at cytokine inflammatory markers, interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha and C-reactive protein. Now, they also looked at secondary endpoints such as perioperative complications, length of hospital stay, and then if there was readmission within 30 days. Now, I love this slide right here, if you can see, because what we're seeing here is we're looking at the effects of the tumor metastatic biomarkers by that combination of celecoxib and propranolol. And what you see is in the MMP9, that's matrix metalloproteinases, you're actually seeing in the control group a significant increase compared to the intervention group. Now, matrix metalloproteinases, by reducing this with that combination, you can actually see a reduction in invasiveness, a reduction in stimulation of angiogenesis. And you also see this in vascular endothelial growth factor, again, new blood vessel. In the control group, which is the non-treatment group, just surgery, and then in the intervention group, where you have the combination of celecoxib and propranolol, actually reducing the new blood vessel supply growth, that a wound that you've created that cancer can then use. So this is good when we're talking about trying to prevent metastasis or even local recurrence. Now, E-cadherin or epithelial cadherin and Vimentin, these are signals of metastasis. Primarily, they're looking at what's called epithelial to mesenchymal transition. Epithelial cells are very immobile, they're stationary, and mesenchymal cells have the characteristics of more modal, and thus spread. So when E-cadherin is increased, as you can see here between the control and the interventional group. So the Celecoxib and Propranolol increased the expression of E-cadherin that maintains the epithelial-like function, thus reducing the mobility as that found in the mesenchymal type. And here in the Vimentin, you see that is increased in the control versus the treatment, where it's actually reduced. Now, Vimentin is upregulated and is characteristic of mesenchymal cells, which are those more mobile or motile cell types. And again, just looking at some of the transcriptomic analysis of the epithelial mesenchymal transition at the time of surgery. And this was from, of course, the tissue taken. Now, the effects on the immune system, looking at the intervention group here, actually showed increased cytotoxic T cell activation. In fact, significantly higher, almost 50%. There was enhanced natural killer cell cytotoxicity, almost 2.5-fold increase above the control group, which is the non-treatment group. We had a reduction in T-regulating cells, a reduction in myeloid-derived suppressing cells. So what we have here is we have the pivot for the innate immunity upregulating cytotoxic T lymphocytes, upregulating natural killer cells, but downregulating the pro-tumor immunosuppressive myeloid-derived suppressing cells and T-regulating cells. And what you have then here is a pivot in this perioperative time period from the combination of Celecoxib and Propranolol, repurposed medications in oncology, to promote an anti-tumor immune environment and not a pro-tumor immune environment. You know, cancer is tough on its own. We don't need unforced errors. And that's really, I think, one of the things that we can take from this study. So what we saw with the natural killer cell activity, which again, their name implies exactly what they do, there was an increased cytotoxicity capacity in the interventional group, again, the Celecoxib plus the Propranolol versus the control group. And this was found as it progressed from baseline through to the 7 days postoperatively. Now, in the non-treatment group, the control group, compared to baseline, there was a decreased tumor cell killing by natural killer cells. So what this means is that in the treatment group, when you go from baseline to the 7 days postoperatively, there was an increase in the ability of neutrophil killer cells to activate against what you might see as increase in circulating tumor cells. And so this is going to basically blunt that immunosuppressive time frame period that I talked about through 14 days and beyond. But in the control group, where they did not get the Celecoxib or the Propranolol, what they saw is actually, as they progressed through that postoperative time period, was a decrease or immunosuppressive state as we dictated in that timeline. So what this was going to do is this was going to basically allow the survival of circulating tumor cells, allow the potential increase in percentage success of the colonization and thus local recurrence or metastasis. And here you can actually see the effects on inflammatory biomarkers here, looking at interleukin-6 tumor necrosis factor alpha. You can actually see in the intervention group, we have a significantly decreased level of inflammation compared to the control group. And in fact, there was an improved neutrophil to lymphocyte ratio, and overall the inflammation noted was actually 48% lower in the intervention group versus the treatment group. The intervention group, versus the control group. And so what they found in the pro-inflammatory cytokine was reducing the interleukin-6, reducing tumor necrosis factor alpha, and reducing interleukin-1 beta. Now this is important because when you look in cancer, cancer doesn't create anything new. What it does is manipulates everything around it for its benefit at the detriment of the body. And primarily it does that through cytokines and immune signaling. And it loves interleukin-1 beta, interleukin-1 alpha 2, but then interleukin-6. And if you've ever heard the term tumor lysis syndrome, this is where the immune system becomes hyper upregulated, and this promotes cancer spread, cancer recurrence. And here, interleukin-1 beta and interleukin-6, it's a little bit of a quasi miniature tumor lysis syndrome associated with surgery. And this is one of the mechanisms of how the immune systems can actually promote cancer progression. But it's not actually an immunosuppression, but it's actually an upregulation of immune signaling promoting cancer spread. But it creates immunosuppression by downregulating those innate immune cells, such as natural killer cells, cytotoxic T lymphocytes, but also it downregulates the ability of the body to get rid of those immunosuppressive cells by upregulating or allowing in myeloid-derived suppressing cells and T-regulating cells. So the clinical implications here are critical. Number one, add in celecoxib, add in propranolol in patients undergoing surgery for cancer. We know there's an immunosuppressive state postoperatively. We know that. We know these medications are safe. The safety profile on these are long-standing because they are very strong pillars in the repurposed medication and oncology movement. So we know they're safe when properly prescribed. We know how to prescribe them in cancer, and here they actually can mitigate and reduce the risk associated with cancer surgery to actually promote local recurrence and metastasis. Now, they would say it's a paradigm shift, but I would say it's just following the science, to provide better care. These are widely available drugs, again, good safety profiles, and they're affordable. So why not? And finally, when you look at surgery, again, one of the unholy trinities, we want to understand that antagonistic pleiotropy. We don't want a short-term gain for a long-term loss. We don't want to sacrifice long-term just for a short-term win. We want to win short-term and we want to win long-term. We don't want to just get a first down. We don't want to just score a touchdown. We want to win this game called the treatment of cancer. We want to win in life and actually heal patients. So interestingly enough, safety profile of this study, no significant increase in perioperative complications. We'd say, well, we're working in the COX-2 inhibition with celecoxib. Ibuprofen you may be more aware of, that's a COX-2, COX-1 non-selective, but here Celebrex or celecoxib is a COX-2 selective inhibitor, and that can increase bleeding risk, but here in the surgery they showed no risk of increased perioperative complications. Bleeding would be one of those. No delays in wound healing or anastomotic integrity. Anastomotic integrity, that is allowing the blood vessel growth in, and thus by inhibiting that, which we showed through the inhibition of the vascular endothelial growth factor, could that compromise the healing? And actually in the study they showed no. There was no change in cardiovascular dynamics, and the hospital stay was the same between the intervention group and the control group. So the conclusions from this is, I would add, why not? And why wait? See, the key findings are that here, long safety track records of two repurposed medications in oncology, celecoxib, a COX-2 selective inhibitor, and beta-adrenergic blockade with propranolol, modulates the immune system in a very short interval and actually can counter the immunosuppressive state that's normal in that state, but also upregulates the innate immunity that is going to allow us to maintain an anti-tumor immune environment when in its natural non-intervention state, as it relates to the study, it's a pro-tumor immune environment. And here we can maintain proper immune activation, control inflammation, and not allow a tumor lysis syndrome to kick in, and actually undergo surgical resection safely to limit the liability of a short-term victory for a long-term loss, and basically mitigate the potential for antagonistic pleiotropy. So the current limitations, they would say, well, we need larger studies. The safety profile of these two repurposed medications, I think, really negate that need. Now, what they're looking for is they're looking for the ability to remarket these as a new indication, and so that's what they would want there with looking at the dosing, etc. But those doses that they described in that study are the celecoxib 200 milligrams twice a day and the propranolol 40 milligrams twice a day. That's actually where most people use these in the repurposed medication oncology movement. Next step, do we really need phase 3 studies here? I guess if we're moving towards actually getting a additional FDA indication for use, but otherwise these are available over the counter, and a good integrative oncologist can actually employ these now. You don't have to wait for that. So I would say we don't really need that unless there's the need or desire to get another indication for FDA, and of course insurance would then cover that. Here, of course, is a study. I always encourage you to check out this information on your own. The reference here, again, perioperative COX-2 and beta-adrenergic blockade in colorectal cancer, a breakthrough approach published in 2024, the Annals of Surgical Oncology. So a very reputable peer-reviewed journal. And as always, I ask you to stay connected with us. Subscribe to the Prescribed YouTube channel. Again, the Prescribed YouTube channel. You don't want to miss out on the insights where we discuss and dive in to these studies, and we'll bring you them clinical application for the arena of integrative oncology, something you don't have to just wait for phase 1, phase 2, phase 3 study. We're going to dive into these studies that are relevant and applicable today. So go to our Prescribe YouTube channel and subscribe today. And I'll see you on the next Hot Take with Dr. Nathan Goodyear. Thanks for joining us on this episode of the Prescribe Podcast. All references supporting this episode can be found on the prescribe.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.